recording. So it is with great honor that I'm welcoming today a very brilliant researcher and a friend of mine, Sophia from University College London, and she's joining us from there right now. We thank her for being with us today. So first, I would like to introduce her officially. So let me just share my screen, and here we go. All right, so we have with us today at the 7 Future Directions of Artificial Intelligence workshop, Dr. Sophia Bano from the University College London. And it is with great honor that we are hosting her today virtually. So Sophia is a senior research fellow with interest in computer vision and artificial intelligence applications in healthcare. She received her PhD from Queen Mary University of London in the UK and Technical University of Catalonia, Spain, through the Erasmus Mundus Fellowship. So she got an outstanding fellowship. She is now associated with the Surgical Robot Vision Group in the Wellcome EPSRC Centre for Interventional and Surgical Sciences in the UK. And this is one of the largest funding body in the UK, EPSRC. She is working on the guided instrumentation for fetal therapy like babies, cuties, and surgery as part of the GIFT-Surg project. She is keen at establishing collaborations and at international level, and we collaborated on one paper. We should do more. She has worked previously on augmenting communication using environmental data to drive language prediction project as a postdoctoral researcher at the University of Dundee, and that's where we met there. So I'm very delighted to have you with us today, Sophia. And okay, so welcome to the session, and thank you for being with us. And there are lots. I showed you not the empty tables, but we have people with us here. So the floor is yours. I'll let you share your screen and start the session.
Thank you so much, Islam, for a great introduction. And actually, it says the host has disabled screen sharing. So I think you need to allow me some access.
Oh, yeah, of course. I'm sorry. Yeah, here we go. Make co-host. Yep.
Okay, yeah, so I can.
Excellent. Yeah, we can see you.
Okay, so thank you so much, Islam, for inviting me and for this great introduction. And it's my great pleasure to be here today at this workshop presenting about my work on artificial intelligence in minimally invasive surgery. So as Islam mentioned, I am associated with the University College London, UCL, which is actually located in the heart of London, minutes away from all the major attractions in London. Within UCL, I am part of the Wellcome EPSRC Centre for Interventional and Surgical Sciences, where at this center, engineers, scientists, and consultants, they work in collaboration and work together to bring novel techniques into clinical practice. So again, this WEISS Center is formed of several research groups, and I am working as part of the Surgical Robot Vision Research Group, where we are working on devising new techniques for computer-assisted intervention and surgical data science. We are working with clinicians for building applications for ophthalmology, gynae, neurosurgery, fetoscopy, general surgery, gastrointestinal surgery. Then we are also working on computer-assisted diagnosis and medical imaging, where we are analyzing fetal ultrasound or pathology images or periapical X-rays. And a good number of my colleagues are also working on soft robotics and surgical robotics, where we are looking at surgical and soft robots, which can enable highly precise, robust, and safer surgery. So before jumping into the technical or exciting part of my talk, let's briefly talk about what actually is artificial intelligence or AI. Artificial intelligence is the capability given to machines to memorize and learn from experience to solve a task in a way like humans do. And within AI, there is a subset which is machine learning, which uses statistical methods to enable machines to improve with experience. And deep learning, again, is a subset of machine learning, which makes the computation of multi-layered neural networks feasible. Then the second part is minimally invasive surgery. So minimally invasive surgery, also sometimes referred as keyhole surgery, is a procedure which is performed through small insertions instead of large openings. There are several advantages of minimally invasive surgery where the duration of hospital stay becomes shorter. It introduces less trauma to the patient, less pain and less blood loss, and smaller skin scars. But while there are many advantages, there are some limitations on the clinical side or towards the surgeon side for minimally invasive surgery, where this procedure can be performed only by specialist surgeons. The field of view in minimally invasive procedure is really small. The maneuverability given to the surgeon is very small, and all these introduces or increases the cognitive load of the surgeon. So with AI, why we need AI for minimally invasive surgery? These limitations that I mentioned can be overcome with the help of AI. AI can improve the surgical outcome. It can reduce the risk of errors and complications, and it can reduce the misdetection rate and persistent occurrence of a condition. In my today's talk, I'll be covering several topics I've been involved in related to AI in minimally invasive surgery. And specifically, I'll be talking about fetoscopic surgery, which from past 3 years, I've been working on as part of the GIFT-Surg project. And alongside, I've been involved in several other projects, which I'll be briefly talking about. So from today's talk perspective, we'll be talking about mosaicking or field of view expansion in fetoscopy, surgical event detection, surgical scene understanding, which can help create an overlay of different semantics of the scene and can help the surgeon in better guidance, classification and detection of anomalies or lesions through automatic AI solutions, surgical workflow analysis, and in terms of soft robotics, identifying the target area where the drugs can be delivered for using a soft robot. So moving on to the first topic, which is fetoscopic surgery. Fetoscopic surgery is used for the treatment of twin-to-twin transfusion syndrome, where fetoscope is a very miniature endoscope with a very small diameter of about 1 to 4 millimeter and a working channel length of 20 to 30 centimeters. It has a monocular camera that guides the surgeon during the procedure. During this procedure, a fetoscope is inserted through a small incision in the abdomen into the amniotic abdominal wall and uterus into the amniotic cavity, and then it is used for doing the treatment. So twin-to-twin transfusion or TTTS is a fetal anomaly which affects identical twins sharing monochronic placenta. It affects about 10 to 15% of the monochronic twins, and if left untreated, it leads to fetal mortality or abnormality. During this condition, the flow of blood between the two fetuses becomes uneven. As a result, the donor experiences much slower growth, while the recipient is at a risk of heart failure. So fetoscopic laser photocoagulation is the technique that is used for treating this condition. Where in fetoscopic laser photocoagulation, the surgeon first visually inspect the placenta using the fetoscopic camera to find or to identify the abnormal connections or vascular anastomosis sites. Then once these vessels are localized, then the surgeon uses a laser tool to ablate these vessels to disconnect these connections so that the flow becomes even. For a safer procedure, it requires clear view of the placenta and free of occlusion and free of presence of fetus in the environment or in the local neighborhood, and a clear path between the ablation and the target vessel. There are several clinical challenges in this procedure, as I mentioned before, while talking about the challenges of minimally invasive surgery. Firstly, is the very narrow field of view and constrained environment in this very delicate procedure, and then poor visibility, because at times the fluid turbidity is so high that it is hard to see through this intraoperative environment. This can result in missed anastomosis and can result in persistent TTTS condition. So we started looking at mosaicing or image stitching for increasing the field of view of surgeon in this particular fetoscopic procedure. This kind of technique can be extended to any minimally invasive procedures as well, but here we are specifically targeting fetoscopic surgery. So mosaicing is basically used to align overlapping images to generate increased field of view image of the surgical environment. It helps in mimicking surgeon's cognitive load, and it aids in the localization of vascular anastomosis sites. So here I would like to quickly ask a question. So have you ever used your mobile phone for creating panoramas? I'm sure all of us have done that, where whenever we see a nice landscape scene, we try to stitch or create a panorama using our mobiles. This experience is quite nice, but I doubt many of us have tried creating a panorama from a textureless scene, for example, of a sky, or even, let's say, of water surface. So in these kind of scenes, since there is no texture, there are discontinuities, and the generated panorama may not be very nice or appealing. This is acceptable in image processing or in our photo libraries, but this is not accepted in mosaicing for fetoscopy or minimally invasive surgery, because this introduces error in the generated mosaic, which can misguide the surgeon. So from the technical perspective, these fetoscopic videos here, I'm showing some clips from 6 different videos. They have poor visibility, low resolution, low illumination, and fluid turbidity, and occlusion due to the presence of fetus or working channel port, specular highlights and reflection, and dynamically changing views. This results in lack of long-term consistency in the mosaicing algorithms. So we are looking at designing novel deep learning-based solutions that can overcome these challenges. So I think my computer since this morning is giving some green screen issue, but if I do this, yeah. So we are developing deep learning-based techniques for mosaicing, where in our initial work, we tested sequences of phantom placenta or simulator of fetus in a simulated environment, and then in vivo or in vitro placenta sequence. Here in this initial study, we managed to get very reliable mosaics, yet there was drift in the sequence, which is makes the clinical analysis a bit more unreliable. So one common feature in fetoscopy video is the presence of placental vessels, which can help us in improving the mosaicing algorithms. So we started looking at vessels for segmentation for doing mosaicing. Since vessels has dual purpose. So if we can identify the vessels, they can help the clinicians to find or better localize the anastomotic placental vessels. And it can also act as a unique feature for registration and mosaicing. So in this way, it can overcome visibility challenge, and it can guide in the localization of the vessels as well. So in one of our recent work, we developed a deep learning based technique for placental vessel segmentation using the well-known UNet architecture from deep learning, where we manually annotated a data set of about 500 images from 6 in vivo fetoscopy videos and used it for training our network. Then once we get these segmented vessels, we use these segmented vessel maps and apply a direct registration method for creating the vessel mosaics. In the same way, the transformations that we obtain from the vessel mosaics, they can be used for RGB frame registration as well. So this is something that we get as a result of using placental vessels for mosaicing. Many of the visibility challenges in lighting conditions and the presence of moving occlusions are filtered out, and vessels are found to be unique, recognizable shape. But here again, there is some limitation, because there are some parts of placenta where either the vessels are very thin or they are not present. So in that kind of situation, this algorithm may fail. So here I would like to point the audience to our data set, Fetoscopy Placenta data set that we released last year. And if you are interested in segmentation or registration problem, I would encourage you to check out this data set and do reach out to me if you have any questions. So let's also have a look at a few more results from this, where I am showing in this slide comparison of vessel-based method with a direct image registration method, or RGB image registration method, where we can clearly see there is noticeable drift in this sequence, while vessel-based registration method is quite accurate. And in this example at the lower side, you can see that image-based method tends to lose tracking, while the vessel-based method is quite consistent. Along this same line, our current data set is captured from only one center, or at UCLH. We started looking at collecting a large-scale fetoscopy data set, and then we organized a challenge in one of the top conference, MECAI, this year, where the idea was to crowdsource this problem and get the solution for placental vessel segmentation and placental RGB frame registration for mosaicing. Again, here I would like to encourage you to check out this challenge website. Here is the link to that. So, fetoscopy video itself is about 20 to 30 minutes long, but with the current methods, we are only focusing, mosaicing methods, we are only focusing on segments which have a clear view of the placenta, and then using these for mosaicing. These are just a couple of seconds long segments. So can we then say that mosaicing is solved for fetoscopy? Not yet, actually. The end goal is that we can analyze the whole sequence of fetoscopy and can better localize or relocalize the vessels and map them simultaneously in this environment. So in this regard, we started looking at fetoscopic event identification, where segments of fetoscopic videos where there are occlusions are not suitable for mosaicing. And while doing fetoscopic event identification, we can filter out these segments. For this task, we generated a frame level manual annotation data set from 7 fetoscopy videos, and then use this data set for training spatiotemporal models for event prediction. So here you see some quick result where we can see in the field of view there is some occlusion because of the presence of fetus, and this is detected by the algorithm. Let's have a quick look at one more qualitative example where the ground truth is labeled here in green along this axis. The predicted probabilities are shown here, where in blue is the result from our method, and then the predicted labels are shown with the colored box filled with yellow. And again, the focus, we can keep our focus on the blue ones, which is our method, and it is being compared with 2 other methods. So again, here we can see in this scene, tool and occlusions are present, and the methods are able to detect both these events. And in this second example, occlusion, tool, while it is oblating, so it is shooting the laser, is present. And again, the algorithm works quite well in this scenario as well. So along this same line, event detection kind of algorithms can be related with the surgical workflow recognition algorithms as well, where in surgical workflow recognition, we are interested in segmenting or detecting the different phases of a surgery. So each surgical procedure can be divided into different steps or phases. And by measuring these different phases, we can train the novice surgeons to become more expert surgeons. And it can also help in monitoring the procedure for any errors as well. So here we see an example from cholecystectomy data set where the procedure is split into 7 different phases, which are listed over here. And the timeline or duration of each phase is represented in this color bar over here. So just to sum up what I just said, surgical workflow is essential for context-aware computer-assisted intervention systems, which can monitor surgical phases, optimize staff scheduling, provide assistance to the surgeon, automate the indexing of surgical video database for skill assessment, like training to expert surgeon and upward curve analysis. And then it can also help in alerting the surgeon for a possible complication in the procedure. So at our center in WEISS, we are working on surgical workflow analysis for two surgical procedures. One is sacrococopexy, which is a surgical procedure used to treat pelvic organ prolong. And then the second one is endoscopy pituitary edema resection, which is performed through the nose to remove tumor from the pituitary gland and skull base. In these works, we are interacting with gynecologists and neurosurgeons for collecting the data and getting their expert knowledge in these particular kind of procedures. So moving on to another example or another work that we are doing is an anatomical site classification for upper gastrointestinal endoscopy, where GI and biopsies are gold standard procedure for diagnosing gastric cancer. It is a widely used procedure, especially in geographical regions with high disease incidence. And early gastric cancer and other significant pathology can be easily missed during GI endoscopy due to potential blind spots. Therefore, mapping of these upper GI tracts through the use of standardized photo documentation is considered a unique indicator. However, there are various guidelines, and it's challenging to find a specific guideline that can meet the need for photo documentation. And manually annotating these photo documentations is time-consuming task for the clinician. as they have to go through the whole duration of the procedure to find the relevant frames. So there is a need for automatic photo documentation method to support and efficiently improve the quality of endoscopy. In this regard, we started looking at fusion of two guidelines, one from the Chinese guideline and one from the British guideline, where they observe different regions during GI endoscopy, but the number of regions observed in British examination is much more fewer than the one in Chinese. While in the one in Chinese examination, they are so much spread out that the clinician never view those views or observe those views during the GI endoscopy. So we propose a hybrid of these two guidelines, and as a result, we came up with 11 classes and a non-applicable class for observing these different regions in the GI tract. These are the most relevant sections which are prone to have some signs of cancerous tissues and are the most important ones to be observed. And then we trained deep learning networks for the automatic classification of these networks, which can then enable automated photo documentation and reduce the load from the clinical practices. So moving on to the final topic that I want to cover today is on fluidic soft robot for intratympanic steroid injection. So hearing loss affects a large portion of global population. The World Health Organization estimates that around 500 million people worldwide are affected. Of that, sensory neural hearing loss makes up to 90% of the burden. So intratympanic steroid injections are offered as an effective treatment, but there are risks since the treatment of the inner ear is quite difficult. So such injections are commonly administered by trained ENT surgeons and require the use of large microscope to provide a close-up view of the site. So at WEISS, we have been designing and developing a soft robot that can support this particular type of procedure, the intratympanic steroid injections, and can actually improve the outcome of these steroid injections or drug delivery. This work is led by my colleague Lucas, who is designing this robot, and we already have a prototype of this robot up and running, where fluid activated robot is used for steering the needle and pointing the needle to the right quadrant of the tympanic membrane that can be then used as an indicator of a safe point where the needle can be inserted for the drug delivery. This novel robotic system has the potential to significantly de-scale this procedure, ensuring more accurate drug delivery. Here, I would like to also mention that alongside the robot design and development, we are integrating AI and vision with this robot that can help in targeting the site or a site that can be used for the drug delivery. So to sum up, what's the future of AI in surgery? AI in surgery can help in intraoperative guidance to the surgeon. And as I've mentioned, through mosaicing, field of view expansion, this can reduce the cognitive load of the surgeon. So this can provide real-time and highly precise solution with high resolution virtual overlay, as we can see over here. And on the other side, surgical robotics can provide high precision, robust, and real-time safe solutions. These kind of systems are already being implemented in virtual environments where they are used by trainee surgeons for getting trained for particular kinds of procedures. So in the end, I would like to thank you all for your attention. And if you have any questions, I'm happy to take these questions, and feel free to reach out to me even after this workshop session. Thank you.
Thank you, Sophia. Let's give her a round of applause here. Okay, so I think, let me just turn this on. Okay, so maybe you can, if you would like, you can stop your screen sharing and we can have a conversation so they can see you in high resolution. Great. So I know this has been so heavy for many of you, like a lot, like we were about to have lunch and there are a lot of like, you know, photos that are a bit, you know, provocative. So I wanted to ask you, could you stop the screen sharing? Yeah. Okay, yeah. Cool. So awesome. Now we can see you full screen and I can just, you know, put you right here. Okay. So I do have a few questions. Excellent. So any questions from the audience, please feel free to ask. So I know that you're using, we were talking this morning about AI and how it is basically, you know, like we were talking about the issues of reproducibility and generalizability to unseen data. So you have been collecting a lot of data from different parts of the body, fetal data, you know, intestine data, and all of those videos, you're feeding them into your AI system to do prediction, to detect abnormalities, or to, for example, you know, like insert, you have now like robots that you're sending AI-powered mini robots into the ear, and they can smartly find the place where to be, like, you know, where they need to act, basically. So this is all impressive, and it's like really high level research and high level work when it comes to using AI inside our bodies, right? So the question that I have is like, how much can you trust it? So basically, in terms of reproducibility, we have seen that if you change the data, you might not have the same exact accuracy. Okay, and you're about to insert something into a human body and like let it decide on its own what needs to be, you know, to be done, basically. So what are the challenges to that? How much accuracy we need to have to trust a model? How much can we trust? These are the first questions, and then we can go to the next ones.
Yeah, so yeah, that's a very, very, very good point, actually. So if we cannot trust them, we will never take them into the patient. So this is the first point. The second thing I would like to highlight is that, yes, if you get new data from a different center, these models does not work. And that is the issue with AI, and that is the issue with deep learning as well. It needs big data, and it needs more and more data to create generalized models. So for addressing this second problem, as I mentioned, we have been collecting multi-center data from different sites across the Europe on Fetoscopy. And then in the first round, we are annotating part of this data for training the model. In the second round, we are looking into moving ahead to other types. So this first part is called supervised learning. So in the second part, we are moving towards semi-supervised or self-supervised learning, where we have a big repo of the data, which is unannotated, and a small repo of the data, which is annotated, and using this annotated data to generate pseudo labels for unannotated data so that we can improve our models. Mm-hmm. So in this way, we can create more generalized models, which can cover a wide spectrum of for example, this particular kind of fetoscopy view segmentation problem. And then now coming back to the first point, where is it safe AI in humans, taking AI into human? So there is a standard protocol of taking or designing a technique, AI technique, and then taking it to clinical practices. Most of the work that I've shown today here is at research level or investigation level. Taking this into clinical practices will require first achieving, let's say, 99% of the performance. Second, getting a proper route, proper ethical route that in which experts are involved that have even more concern about patient safety. So through this approval, we can only then take the solution into clinical practices. And then, having said that, when we talk about taking AI into clinical practices, we are not saying we are at this level where we are not giving the full control to the robot, let's say, or full control to the algorithms. These are algorithms are for supporting the clinicians. Even the robotic solutions are for supporting the solution. The main the clinicians. The main task is still performed by the clinicians, where they get, for example, an expanded nice view of the placenta, so they don't have to think too much about where should I go, or an overlay of hidden vessels in the scene. So they can see hidden vessels in, for example, cholecystectomy procedure. They can this will reduce the risk of error or cutting a wrong artery, for example. So that is where the AI is taking us right now.
That was a very extensive answer. Thank you. So to summarize, so first you had multi-center data. So they collect data from different hospitals, right? And that's how you can generalize, because you're training your model on multi-center data. The second, you mentioned about self-supervised learning or semi-supervised learning, which means they're using labeled data, but data without labels, without any targets. There is nothing we know about the target or the output of the data. Still, we can use that data to increase, remember, the space that we had about the data, the possible observations. So I'm connecting to what we had earlier. And the third point, which is so cool, you said it's not AI that is in control, it is the clinician who is in control, but he's using it and he's monitoring and supervising. So it makes sure that whatever we're using is not, it's not harmful. However, I do have a question. So how far are we from the translational stage where we take AI to real hospitals, to real surgeries with that 99.9% or 1%? How far are we from there? So I know this has been exploding with all these deep learning models and architectures, and we're going to talk about that later on a bit more. So how far are we actually from the real translation of AI into clinical hospitals and facilities? What is your vision?
Yeah, actually, that's a very, very good point. And as part of WEISS, I am aware that once we have a technical system or a model that is outperforming even the clinician. So we have trials where we kind of offline first test these models and compare their performance with the expert clinicians. And then we have taken this initiative of creating small startups that take these solutions into clinical practice. So here I would like to actually highlight one of the startups that we have in WEISS, Odeon Vision, where they are designing tools for polyp detection in colonoscopy. And these tools are already being taken into clinical practices, not just trials, but these are now used in clinical practices where they are reducing the risk of, for polyp detection, there is a high risk that the clinician can miss some polyp sites, which does not look they can have various types of shapes. So which does not look like a polyp and they can miss, where AI can detect these sites. The other thing is there is a possibility that while moving the endoscope or colonoscope inside the patient, they can miss some regions, but these AI tools provide an indicator of if there is anything missed. So yes, for some particular procedures, these are already being applied into clinical practices, while for other procedures, this is still at research and investigation level.
Thank you. Well, that's fascinating. So basically, you mentioned about this startup where they're like, actually they're using these things. Awesome. So I have something to say about like another thought about this. So basically, so once you have a startup and you're doing these non-invasive surgeries and you're using AI, you mentioned something that really struck me. So you said AI-powered endoscopy outperformed clinicians, because sometimes we might miss out something, right? So like you have mentioned you have shown through these clinical trials that sometimes it can outperform, but when we use it to augment our capacity. So we want to have better clinicians. We want to have, faster diagnosis, more accuracy in whatever surgery they're performing. So the last question I want to ask, if we don't have any more questions, is AI our ally or our enemy? Because, you know, sometimes you think about, okay, if AI will be able to do all these things, sometimes it might take my own job, right? So how do you see this balance in, like, you know, the next 10 years, or like particularly in medicine and clinical, you know, non-invasive surgery area?
So I would not say AI is our enemy. That is a picture that's been portrayed through all these sci-fi movies. So that and there, not even in the next 100 years, AI is going to empower us. Let's say take over us. So that's a kind of wrong misconception. Then AI is kind of a support tool that is enabling better surgery, improving the surgical outcome. And without there are scenarios in this very constrained environment where they use endoscope for, let's say, viewing the surgical environment or the intraoperative environment. AI is just providing some guidance in this environment, and it is reducing the risk of any error that a surgeon or clinician can make. And if a surgeon is making an error in these procedures, that results in them redoing the procedure, which can be a bit not nicer for the patient as well. But with this AI support as a tool, it can help in better localizing these abnormal sites, and better ablating these sites in the first round, so that they don't have to re-perform this procedure over and over again. So yeah, I would say AI at this stage is the support tool, which is providing just the guidance for the surgeon, removing the cognitive load that they have in what. So if they have to perform like 10 procedures in one day, they might get exhausted by the end of the day. So AI is actually supporting the surgeons in different kinds of surgery.
So it's our good friend. Cool. Thank you so much, Sophia. Any questions from here? Anyone else at all? Okay, I would like to thank you for joining us today, and thank you for giving us, you know, some new insights about the world of surgery. Yeah, so that was a great talk. Thank you so much, and take care.
Thank you so much. Thank you, and have a good rest of your day and a nice workshop.
Thank you for joining us today. Thank you.